Good afternoon, everyone, and welcome to our webinar this afternoon, the Cardiac AL Amyloidosis Bridge, Connecting Patient Stories to Expert Care. I'm Karen Bertozzi. I'm with the Mended Heart staff, and I'm thrilled that you are here to get educated with me this afternoon. A few housekeeping items before we move into the session. All attendees are in listen-only mode. We will not be able to answer any questions related to your specific condition. Be sure to type your questions into the Q&A box so we can answer them at the end of the discussion. And this webinar is being recorded and will be available on the Mended Hearts website and our YouTube channel. We'd like to say a quick thank you to Alexion for supporting us and bringing this education to the community. And the structure of this discussion this afternoon, we have two amazing physicians that are very experienced in patient care within amyloidosis, and then we have two patients that are willing to share their stories and their journey with us. So we're sure to learn a lot from all four of our the speakers on our panel this afternoon. I'll introduce everyone first. So Dr. Masri, welcome. He specializes in caring for patients with conditions that, specific to the heart muscle, specifically cardiomyopathies, with a special emphasis on genetic cardiomyopathies, hypertrophic cardiomyopathies, amyloidosis, and Fabry's disease. He trained in internal medicine at Cleveland Clinic. He has done additional training in cardiovascular medicine at the University of Pittsburgh, and he's an expert in cardiac imaging. He spent 2 years at the University of Pittsburgh supported by a grant from the NIH, focusing on cardiac magnetic resonance imaging, nuclear cardiology, and echocardiography. So welcome, Dr. Masri. Our next physician, he likes to be called Dr. Tax. He likes to keep it easy. So Dr. Tax, welcome. He comes to us this afternoon from Mayo Clinic in Rochester. He specializes on rare dysproteinemias, including amyloidosis, among others. His research aims to identify mechanisms of tissue damage in amyloidosis and improve patient outcomes with the disease. His work utilizes systems biology, approaches to understanding organ toxicity, and has identified complement deposition as a key driver of tissue damage in amyloidosis. He has received funding also from the NIH, Mayo Myeloma Spore, Multiple Myeloma Research Foundation, among others. So welcome to both of our clinicians, our physicians. We're thrilled you're here. I'll do a quick introduction of our patients as well. Welcome, Karen Harris. She was diagnosed with AL amyloidosis in July 2014 following a kidney biopsy. Further testing revealed involvement in her heart, nerves, gastrointestinal tract, and thyroid. Her cardiac condition was identified through an EKG and echocardiogram at a specialized amyloidosis center. So welcome, Karen. And then we have Myria Grace, who is joining us from the Pacific Northwest. She was diagnosed with AL amyloidosis in August of 2025. She works in real estate investment management. She's an author and she leads grief recovery support groups. And she is passionate about empowering individuals. So welcome everyone. And we'll get started. We'll just keep it back here. I'm going to go back to our initial slide just to keep everybody focused. So the way this will work is I have some talking points and I will certainly, share those with the group and then we'll just have an open discussion. So Karen, what was your first red flag that felt like heart failure? Could you share a little bit about that?
Yeah, I was a very active person before diagnosis, involved in a lot of sports, did a lot of activities, was rarely sedentary. And I noticed I was unable to do those things any longer. I at first thought those things were, it was just age related. And as I was getting older, I just, was unable to do it. I had a job that my office was on the second floor, and I couldn't manage the stairs. I was the only one in the office that took the elevator because I couldn't manage the stairs because I would be so out of breath by the time I got upstairs to my office. I would feel like I was going to pass out. And just doing simple things like walking to the mailbox and walking back, I could feel that I couldn't breathe for such a small effort. And that's when I started suspecting there was some heart involvement and something else wrong, not just my kidneys.
And Dr. Masri, can you sort of elaborate a little bit more? Karen just shared with us her red flags. And what are the specific red flags that I guess you're looking for on an echo or an EKG that distinguishes AL from standard heart failure? What do you see as you compare those images?
Yeah, great question. And thank you, Karen and Mara, for being here as well. The challenge with AL or amyloid in general is that if you're going to have shortness of breath and you're going to maybe, have chest pain or pass out or have leg swelling, is that there are many, many causes of these things that come up. And so, as the disease advances in some patients, there are actually specific clinical red flags that also get missed as well. Many of you are aware of these. For example, you start saying, well, I taste things differently. I feel my tongue is getting bigger. I have like this skin bruising. My eyes, people are telling me there's something around my eyes, this and that. But the reality is, if you go to someone, a physician, a provider, and you tell them you're short of breath, so they're not going to think of amyloid as the first thing. Now, typically the workup is though the same for shortness of breath, which is usually you would go with an EKG. You can check some labs sometimes, make sure there's no anemia. And then the EKG can show, not in everyone, in actually less than half the patients, it can show something called low voltage, which means that because of the amyloid sitting in the heart muscle, that electrical signal that we pick up from the heart becomes shorter in its amplitude. And so, but that's again not very common, and most people glance through it as well. And then when you do the echocardiogram, if you are early in the disease journey, the echoes are actually not classic whatsoever. So they get missed all the time that someone can have disease. But if it's an established disease that is progressing with really significant burden, the echo can become slowly more classic, where you have some thickening, not a lot, but the heart itself, instead of being a pump that shortens and lengthens and does different motions, it actually becomes restricted. And the problem that many of you probably have experienced is the fact that the condition is so or relatively uncommon that even when a cardiologist sees that on the echo, it doesn't necessarily light up in their brain that this could be amyloidosis or light chain amyloidosis because the walls are relatively on the thinner side. They're not very, very thick like we see in other kinds of amyloid, for example. And, these cardiologists are reading 50 echoes a day. And so this would be one out of, 10,000 echoes that they've read. So it doesn't register easily. One of the most important red flags is that you, as a patient, are leading a healthy lifestyle. You don't have a lot of problems or illnesses. You used to be very active. You have no diabetes, no uncontrolled hypertension, no advanced other problems, and suddenly you have heart failure. And these heart failure symptoms are dramatic usually. That on its own, we always teach our trainees, you have to think, why would this patient get heart failure to begin with, or shortness of breath? And I think that's a much more important story in my mind compared to what you initially see on imaging, because it can be very difficult to separate things on imaging.
Thank
Yeah,
you.
it's very hard to get from your primary care physician into the cardiologist who may have suspicions, whereas the primary rarely has, you're getting older. I was 53 when diagnosed, so you're getting older, that's just how it is. You just need to exercise more. You've been putting on weight, so those kinds of things. And it was very hard to get past the primary to get to a cardiologist who started showing, looking at this suspiciously and said something ain't right here.
But Karen, you had the conversation with your primary care person that you felt, or did you already have an established cardiologist, or you brought it up to your primary, suggesting that perhaps you needed to go to a cardiologist?
I did not have a cardiologist, and in fact, it took many years to get past the primary care physician, thinking that it was just other reasons, age related, that I, was mentally struggling with something, depressed. Perhaps it was, you know, other reasons. The weight gain, which I found out later was about 40 pounds of fluid. Um, but they were just attributing it to weight gain.
Mhm.
So it took a lot to get past. But again, as Dr. Masri said, it wasn't anything that was like huge and outstanding that would make the primary care physician sit back and go, oh my gosh, that sounds terrible. It was all things that were just kind of general, and malaise. I was very fatigued, very tired, and a lot of those things that, the doctors said, well, maybe you just need to rest, take a couple of weeks off, go on a good vacation, cheer yourself up, you're, down. Things like that were brushed away because none of the symptoms were anything large that got someone's attention immediately.
Mhm. Yeah, yeah, that's interesting. Well, and sort of moving on from there, we have this session is called it talks about a cardiac amyloidosis bridge because there is such an importance in patients connecting and getting care from so many different places and different resources. And Dr. Tax is an expert in hematology. And I just want to start with Mariah, if I can. Did you have any non-cardiac symptoms before your heart was involved? So anything related to your nervous system or renal, kidneys?
Yeah, absolutely. Before my kidneys had filtered at a really high rate and my kidney function was actually decreasing. There was a lot of speculation for my primary care that I had some kind of anemia issue. And that was why I was feeling so tired and fatigued. And, I did have nerve pains, and they were all like, well, all of this could be attributed to your extremely low iron. um, it wasn't until later my primary care actually ended up getting transferred to a different clinic, and so I had a new doctor. He was kind of young, and he was immediately like, I'm worried about your heart. He was the one who was I was kind of in denial, like, what do you mean? Why do you think this is my heart? And he immediately referred me to a cardiologist who didn't know anything about amyloidosis. My imaging did come back with thick heart walls, but that had run in my family. My father had passed away from heart failure at the age of 70, and being also 39 at the time when I first started having symptoms. And being a mom to a fairly young child, they were just like, well, you're just tired because you're busy with your kid, this is just normal stuff. And I was thinking, absolutely not. Like, I used to be an Olympic weightlifter. I used to run, 5 and 6 mile jaunts, and I can't even go up a flight of stairs anymore. Like, I could relate to a lot of what Karen was saying, but being a lot younger, it was much more alarming for me.
Sure. And Dr. Tax, so what kind of workup would you do? What blood and urine tests would you typically do on a patient like Mariah?
Yeah. Once I think basically what we're saying here, the most difficult thing is thinking about it. Once you think about it, we can talk about the tests and everything. And these are, at least for AL, pretty standard and easy. So, I mean, I think when you first start suspecting amyloid, right, you kind of zoom out and say, is this going down the AL path or is it going down the ATTR path? At least that's why I think about it. Um, and you have other weird types of amyloid that realistically these are the two ones you're probably going to see. The other ones are like very, weird zebras. So um, to do that, you need simple blood tests like The AL type is due to a protein, an abnormal protein, right? That's floating around. We call it monoclonal protein. It's coming from these, cells called plasma cells, and they're easy blood tests to kind of pick that up. So you need a combination of tests called free light chains, and I think the AL patients in the group will know all that stuff. It's part of their monthly workup. Free light chains, or M spike, and these are kind of different pieces of the puzzle. If you see these, um, it AL becomes more likely, and you should start thinking down that route. Now, having said that, these proteins can sometimes be there at very low levels in otherwise normal patients. Um, they can circulate. With these sensitive tests we have now, you can see them like, say 5% anybody above the age of 55, which is, millions of people. So the fact that you are thinking amyloid, maybe you're seeing one of these, doesn't necessarily mean it's AL. It could still be TTR, but if it's not there, it's for sure not AL. So I would start with that. And then you kind of go down the sort of, quote unquote, $1 million workup with echocardiograms, cardiac MRI. It's kind of going after, what organs are involved, right? And how badly are they involved? And this can be, unfortunately, there's no like magic scan yet. I mean, there are some scans that kind of are not always used. They're only available in specialized centers. They're kind of tricky to interpret sometimes. But there's no scan that'll be like, oh, we'll do it, and yep, there's your amyloid kind of thing. But you do echocardiograms, cardiac MRIs, PYP scans, and stuff like that for your heart, and then urine collections to see how badly your urines are affected, and then you can do more specialized testing for nerve involvement, electromyograms if you really want to see it. Although most of the times you can identify it clinically, right? Or you can do tilt table testing to see if your autonomic nervous system, which controls patients' reflexes, is affected. These are some of the routine tests, definitely not an exhaustive list.
And Dr. Tax, the SPEP and the UPEP, those are part of the urine testing that you do?
These are blood and urine. So stands for serum protein electrophoresis, and U is urine protein electrophoresis. Basically, it's just and here, I mean, if you can Google it, basically you can see like a gel. They get all your proteins, they spread them out, and usually you see kind of a typical pattern in a normal patient, but you see some kind of thicker patterns in patients that have these monoclonal proteins. That's one way to identify that.
I see. Okay, so let's go on to talking about finding the source and kind of connecting all the dots. So, Karen, I'll circle back to you. And how did you react to learning that your heart issues was really coming from a bone marrow issue?
Yeah, I didn't understand it. In fact, it's kind of funny because they called me at home when I got the diagnosis of amyloidosis. And they called me at home to tell me that that's what I had. And I had to call back and ask them to spell it because couldn't get enough letters from what he had told me to even look it up and find out what this weirdo disease was. So I didn't really understand that. And it took quite some time to even understand that all the organ involvement, because I was so focused on kidney at the time, but yet I had these heart issues. But it was troubling to me to find out that you had two different problems to attack, right? You had the problem of these misfolded proteins attacking in your organs, but you also had to shut down the factory that was making them. And so that we could do one, but we weren't good at the other. And at the time I was diagnosed, there weren't that many treatments available. And so I went on the standard CyberD at the beginning. And but it wasn't going to do anything to remove all of the damage that had already been done. And so that was a hard pill to swallow. Being diagnosed wasn't all that great in the first place, but to find that out shortly down the road that all of this damage, as bad as I was feeling at the time, may be how I'm going to feel for the rest of my life. And so that was pretty scary and disappointing. It's different now. I don't feel near as bad as I did then. So things do heal and things do improve, even though we still don't have the depleters available to us yet, to go back and remove them from our organs. Our bodies are still quite capable, or seem to be, of doing some healing on their own. So it was shocking to me to find out that I had two different basic battles, to fight.
And I imagine my own experience, I don't have amyloidosis, but as time passes, the mental part, you sort of kind of get used to. You get a little bit more of an understanding, and you can sort of ease into your new place, I guess. I know for me anyway. And Dr. Tax, could you speak to us about the light chain factory and actually how these proteins become toxic and choose where to land? Like, why do they end up in the heart, and why other times they end up somewhere else?
Nobody knows. But it's a very good question. So yeah, I mean, in AL, you have um, these clonal plasma cells. Plasma cells are blood cells. And again, I don't want to, this is a sophisticated audience, so I don't want to but I'll start with the basics, assuming some people are maybe ATTR. And so clonal plasma cells that are usually making antibodies, nobody knows why all of a sudden they become kind of identical brothers and sisters. They make the exact same dysfunctional antibody. As I mentioned, these are very common in the general population. Most of the times they just kind of sit there, don't cause anything, or we kind of watch these people every few months or once a year in case they progress into like some blood disorders. But in amyloid, and this condition is called MGUS, monoclonal gammopathy of undetermined significance. Again, very common, usually benign, kind of watch it. Amyloid has been called the MGUS with an unlucky protein because usually these are kind of low burden, indolent cases that they make a sticky protein. Why this happens, we don't know. Um, they we and others have done some larger studies, and you kind of see that when you look at our immune system, right? As I said, these are antibodies that have kind of gone rogue. Our immune system uses kind of a full panel of its genetic material to make these antibodies so it can give them kind of a diversity, right? So it can be able to adapt to various different bacteria, viruses, and stuff like that. When you look at patients with amyloid, they use a very restricted repertoire of genes. So it's something about these genes and about how this kind of ends up folding the protein, or I guess misfolding in this case, that is part of a big part of the puzzle, because you can see that there's very specific genes that are much more commonly used in amyloid. So that's number one. Now, what's driving these genes? Who knows? If it's past infections, if it's past exposure to various different sort of antigens, allergens, environmental factors, nobody knows. This is just kind of guesstimating, right? Uh, so that's one. Um, what makes these different proteins go into different organs? Again, we don't know. I mean, you can see a huge variability, right? These are all great kind of holy grail questions in the field. You can see lots of variability, even within, um, patients, kappa versus lambda. As you know, there's two types of amyloid, kappas and lambdas, and for some reason, the lambda type doesn't need a lot of protein to cause amyloid. You can have very low levels of these free light chains in your blood, and you can have lots of amyloid all over. Usually kappas, you need to have pretty high levels. So even just the kappa versus lambda, again, we don't know why this happens. Um, so I guess I didn't answer the question. I just these are major gaps in our understanding. There seems to be some kind of predisposition of some of these genes to kind of be more likely to develop amyloid. We don't know why that is though.
Thank you. Thank you for at least educating us on the process of sort of studying those genes. I know it's very complicated. Mariah, how did you manage having two different doctors for one disease in the beginning? How
It
did you
was
juggle
it
that?
was a disaster. I'm going to be absolutely honest here. It was a total utter disaster. I was diagnosed in the hospital, and the heart failure cardiologist that I had at the time wanted to keep me in the hospital while they were doing the diagnosis, which was ridiculous. I was in there 16 days. And the hematologist oncologist that actually figured out what it was, he's been great through the whole thing. I still see Dr. Parsons, but the cardiologist I had said that he was really familiar with amyloidosis, but it turned out that he was more familiar with ATTR, not AL. And he had only had one patient with AL, and they had passed away pretty quickly. I wish that in the beginning I had asked more questions. Now I know what questions to ask, but back then I didn't. I think anyone who's navigating this needs to kind of grill whoever their providers are to make sure that they have the appropriate experience and knowledge to treat them, because they won't mean to harm you, but they really can. And the cardiologist I had me on a milrinone infusion, which is counterindicated in AL. It can cause severe issues. Had me on low blood pressure meds, or no, which is again a no with AL amyloidosis. And so, there were other things too. Like I ended up with a blood infection from the PICC line from the milrinone. And the cardiology team thought it was a good idea to do a heart cath during that, which was a huge mistake. I was kind of pushed into it. And I was getting a lot of conflicting information. On one hand, I was being told, limit your water intake. Well, I'm having chemotherapy and I need more water because my kidneys are having a hard time. So in the end, basically, after I sort of fired that cardiologist, things got a lot better. I'll be honest. Like from then, and just figuring out what my body needed, doing a lot of my own research, reaching out to the community. Thank goodness for Sally Cox up here, and all of those supporting people and the Facebook groups. I was able to get more information on how I needed to move forward. And now I am one of Dr. Masri's patients, and he and my oncologist, Dr. Parsons, actually talk and communicate about what they think, which is really great.
Right. That's amazing. And Dr. Masri, so on to you. Why does amyloid make the heart stiff instead of weak? And how does that change what medications you use for your patients?
Yeah, and thank you for sharing the story. We didn't plan today to be here, both of us, I think.
No.
And we didn't plan the story, how it rolled out. So hopefully no one goes and tells any other cardiologist that I said they're terrible or anything. But I think, I don't want to defend anyone. I think, from a patient perspective, it's hard because the world revolves around you, which is rightly so. It's your life, it's what you're doing. And some of these other physicians, see many different diseases, and it's not that one is better than another or one is smarter than another. It's just the nature of the beast is that you just need experience. And the more patients you see, the more flavors you see, the more spectrum you see, the more you will understand what's going on. There are a lot of difficult like presentations, a lot of difficult scenarios that happen here. So what happens with amyloid, and the AL is actually different from TTR a little bit, is that it does cause you to have a stiff heart and a dysfunctional heart, and the heart also is weak at the same time. But the way that historically heart weakness is measured is a different approach from what amyloid causes. So amyloid fibrils, as the amyloid essentially is circulating through the body in the blood, these kappas or lambdas or whatever they are, they're sticky, correct? So they like to misfold, so they attain a different structure to themselves, and they stick between the heart cells, or what we call the myocytes. And so the initial insult is the hardest. So the initial getting in there, what we call seeding, getting in there takes time. That's why some patients can have, some of these proteins circulating for a very long time and they never get disease. Some people never do get disease ever, actually, even if they have a predisposition to it. And so once you get into the heart, it's easier to recruit more of these soldiers to come in and start to cause a problem. And so what happens is there are two things that happen in AL, which is different from TTR. For AL, you have the physical space between the cells being occupied by these fibrils that are creating, hard structure that is restricting the motion of that engine, which is the heart. But the second piece of it is that not all the time, that's why some of you can have a 2 centimeter thick ventricle and still feel okay. Some in a lot of patients, especially with lambda, and Tax referred to that already, there is toxicity. So it's the same as having almost an inflammatory condition or inflammation in the heart muscle from those toxic fibers. So as if you have two problems. It's not just the infiltration that is happening, also there is toxicity to these muscle cells, and that makes it become more of an aggressive problem. And that's why it also gets missed, because you don't have a lot of thickening. You could have only normal thickening is below 11 millimeter. You could have an 11 millimeter heart thickness and it's all full of amyloid, because if these amyloid fibers are toxic, they cause inflammation, and that's how it happens. So then what happens is that the heart receives, let's say, a small amount of blood. It's still able to push some blood out, but because it receives little amount of blood, because it doesn't relax normally, regardless of how much it pushes, it's still much, much less than your body needs. And so the pressure builds up in the heart, in the lungs, you start to develop heart failure, and then this fatigue, weight loss, malaise, weakness, all these things also come into play. So that's why, even though we don't actively remove amyloid right now, except investigational agents from the heart, just by getting rid of these light chains, by reducing their levels very quickly if possible, you start to improve that inflammation status. And that's what you all struggle with, or some of you struggle with. And that's why we still every year have, about a third of the patients, at least in our region, present with significant advanced heart disease, because it takes time to, understand what's happening. But also, some of these light chains themselves are aggressive. And so that's another issue that a lot of cardiologists, a lot of primary care are not used to, that there is this rapid evolution of this disease. This is not a very common problem outside of certain acute things like heart attacks, for example.
Thank you. So moving on, let's move into a discussion around treatment and trials. We're sort of calling this the toolkit, if you will. And Karen, what has the treatment marathon been like for you, and how do you balance the chemo side effects with your heart symptoms? What's that been like for you?
Yeah, because I've been at this, 12 years. I've had, excuse me, 6 different lines of treatment, plus a clinical trial that I was in with KAL 101. So dealing with all of the side effects from all those different things has been the biggest challenge. I'm very drug sensitive, which is I picked the wrong disease to have if you aren't very good with drugs. My body just doesn't like any of them. So 0 is, my preferred place, and having to add, drugs and things to it, just my body challenges that on a regular basis. Even during my CAR-T treatment, which was the last treatment that I had a side effect that nobody else has. And I stood there with my oncologist and we both said, of course I did. That wasn't a surprise to any of us that I would have a side effect that nobody else has. But yeah, it's been a real challenge, and trying to keep my blood pressure up and keep the fluid off and not overtax the kidneys. And as Mariah was stating earlier, it's this constant balance of trying to drink enough water to do what your body needs to do, but not drink so much water that you're giving fluid overload to your heart. And, it wasn't this last echo, but the one before, all of my valves were not closing well because of all the excessive fluid. I had been up in the fluid a little bit too much, but I had been feeling a bit dehydrated and was having symptoms of that. I was banging into walls and balance, and my head was just kind of in a fuzzy place. And so there's this constant thing that I have to do on a daily basis of trying to keep all of those things balanced, on top of the chemo side effects, which of course are numerous. But yeah, it's a constant thing. And I'm not calling the doctor every time everything, moves a little bit. It's things I've had to manage on my own. But, thankfully 12 years in, you kind of get a pattern, you get kind of a feel for it. But still, at times it's very difficult to keep everybody happy on a good day.
Curious, Karen, what is you mentioned echoes. How frequently are you having echoes? What's your imaging schedule like?
Typically, my echoes are once a year, but I've been having additional heart issues lately, which is kind of a surprise to all of us because yeah, I'm in remission now, so we kind of expected things to be a little bit more stable. So I just had a recent echo, and my ejection fraction went down. My left ventricle was relaxing, is more severe, they're calling it now. My NT-proBNP has shot up. And so and my AFib is 24/7 now. So some things have changed. We're not sure if it's toxicity related to the CAR T or if this is just something new. I found that very interesting, Dr. Masri, about you talking about the toxicity of lambda fibrils, because no one's ever mentioned that to me before. And that definitely makes sense with, something that's going on now, that my heart is suddenly showing signs of being less happy than it was even before CAR T when I was on treatment. So yeah, the treatment balance has always been a big deal, and being off of it now, I'm in remission with CAR T. So that's a great thing, but I just didn't expect the additional weight of things changing with my heart.
Mm-hmm.
There is an important point there to consider is so not everybody with lambda, for example, or kappa, or any amyloid will have the whole picture of everything, correct? There's a lot of work being done, some of it, around the country, some of it by Tax and his group as well, towards like how can you figure out that which light chain is causing what, and why is this happening? What's the mutation that is leading to this or that? But best for the echo story of it, one thing one has to remember is that the way that the amyloid makes the heart look like, you become very sensitive to fluid shifts and to acute illnesses and to changing in your conditions, either how much blood you have, how much fluid you have on board. Are you in having extra volume on or extra fluid on? Are you dehydrated? Do you have a viral infection, a virus, something? So your heart becomes on echo very sensitive to the point where I get calls all the time from someone who's doing amazing usually, where they tell me, oh, we've done an echo on this patient and their ejection fraction, which a lot of you pay attention to, is low. 90% of the time, that's because of something surrounding that circumstance and not because the amyloid got worse or something else happened. I'm not saying it doesn't happen, it does. But this is why it requires a lot of, thinking and a thoughtful approach to when this actually comes up that, hey, am I having truly more heart dysfunction because of either amyloid or because of something else or whatever it is? Or is it just the circumstances making my images appear as if they're worse? And usually we actually can address those circumstances and repeat imaging as needed.
Dr.
That's very
Sorry, Dr. Masri, if I can just continue sort of along those same lines, what is the hope for amyloid depleters, some of the eraser drugs in reversing heart damage? Can you speak to that?
Yeah, we timed this talk to happen one day after the results were released of the phase 3 trial from CARES, the CARES program. And I'm joking, we didn't time it, but it just happened to be released yesterday. The CARES program was one of the more advanced programs in light chain amyloidosis depletion. And so the first one before it was bertimimab, which some of you probably have heard about or participated in, that didn't work out. And now with CARES, the ensilimumab, the primary results were neutral or slightly or negative, but there was a pre-specified subgroup with the kappa light chain patients showing that there was response to the drug. Now, we don't know if this will become available or not because this is up for the FDA to decide on because the overall trial was still negative. And so they have to think through this and make decisions. But I think that this will be figured out in the future. I personally have no doubt about that. What's happening is we understand the biology reasonably well. We understand the delivery reasonably well. it's a game of chemistry and drug essentially production. And so, because you could have something that works in the lab very well in an animal model, but once you go to humans, human bodies, like, it's very, very complicated. And some drugs that can work, the body can cleave them very quickly and chew them up quickly and get rid of them. So there's a lot of things happening now. The future for light chain, the near future, is that we have two programs that are happening. One is in phase one evaluation called ATO2, and then the other program is still not in the clinic yet. It is by Neuroimmune with collaboration with Alexion AstraZeneca. It's called NI009. Again, these are thought to be maybe second generation, next generation, drugs. The one that I referred to that had positive results is for kappa. The one that NI009 is coming is for lambda specifically. And then the ATO2 one is pan amyloid, which is supposed to be addressing both kappa and lambda. And so again, as I mentioned, it might not happen this year or next year, but I think if we fast forward 5 to 10 years from now, I think this is something that is doable. It's just we have to figure out the secret sauce. How can we get it to the heart or the kidneys or the liver or whatever? But how can we get it? The heart tends to be one of the hardest organs to go after with these depletion ideas. But how can we get the drug to the heart, and how can we have it stick in there so that it can actually remove the amyloid and improve the function? And not everyone needs these, correct? If you are early in your journey, you got treated, with by tax for your, hematological issue, and you have complete remission, or you're in CR, and over the years your body took care of business. You don't need to be offered a depleter or be on a depleter if your organ function is fine and is normalizing. I think the story that many patients are dealing with is that they have their hematological disease under control, and they don't need any more chemotherapy, they don't need any immunotherapy, they don't need anything of these things. However, they're still limited because they still have the heart dysfunction or the kidney dysfunction. And so that's where the depletion, I think, will address that gap. And I'm very optimistic that this is going to happen, but it will take a little bit of time, and it's going to be a collaboration between us and you to have some faith also in doing these, investigational trials and just try to find the right treatment there.
Thank you. Myraya, back to you. How do you and your doctors prioritize which organ symptoms, heart or versus systemic, to address first?
I mean, a lot of communication, as I touched on, things were very difficult there in the beginning, but I think I'm pretty well managed now. Like Karen, I have had a whole lot of side effects from every single medicine I've been put on. If you open a book with side effects, I've had them all. So now I'm in remission, and I'm doing the daratumumab maintenance. And so far, I seem to be doing pretty good, more stable than I've ever been. I would say that, it's a balancing act. I really, really have to be diligent about weighing myself every single morning to see, where my weight's at, if I'm holding on to extra fluid, and I have to, adjust my torsemide to make sure that I'm taking that into account, adjust my sodium intake to make sure I'm taking that into account. And if anything changes, notifying my doctors immediately.
It makes sense. Dr. Tax, why is a complete response so critical for long-term organ survival? And this is in reference to, I guess, the DARA cyborg.
Yeah.
Yeah.
Couple thoughts here. And if you don't mind, Karen, I'll mention like very briefly about the depleters too, because it kind of ties into this, right? So
Sure.
complete response. So when you look at response in amyloid, you have various levels. The first and necessary one is a hematologic response. So basically bringing down these light chains as low as you can, and as fast as you can, and ideally keeping them there as long as you can. And that's what all these, chemoimmunotherapies do. What we know is that, unless you get a deep response, ideally a complete response, so there's some other levels you can kind of get away with right before complete response. It's a problem because your organs are being hammered by a circulating light chain, right? That's depositing into amyloid. So unless you clear it, ideally, or at least minimize it as best as you can, you're not giving them the best chance to recover. The issue is that even if you do that, still some organs don't respond or they take forever. They can take months, years, sometimes you need intensive supportive care. So I guess the answer the question is it's necessary unless you get a deep hematologic remission, bring these down quickly and fast and keep them there, your chance for getting organ response also go down. Now, the depleters, I'll make a comment there. When we say depleters, I guess we kind of mean different things in TTR and AL, but like these amyloid removing antibodies or immunotherapies, I call them, um, they're very safe drugs. Their efficacy has remained a little bit elusive, whether they work or not. And one thing I'm going to put in as a plug to patients, and because I've discussed this with the companies, many of these trials were developed, I feel, as like a big leap of faith. Ahmad mentioned that, right? That they've been tested in animal models, but so take these mice and they get amyloid deposits from like patients that usually come from spleen, and they put them under the mouse, and they give them this antibody, and then the amyloid deposit goes away within few days or a week or something like that. Mice are tricky because even if you don't give them anything, they chew up the amyloid deposits within a few weeks anyways. If you look at the current amyloid mouse model, even though it gets hard amyloid, first of all, it doesn't even always get hard amyloid. And to get hard amyloid in like half of these mice, you need to like inject them with like fibrils to kickstart the process. So they're very resilient. And even though they get amyloid deposits, they are happy as clams. Like their survival doesn't, they live the same as any other mouse. They don't seem to behave anything. So mice are very tricky. So that makes it difficult to develop drugs, right? Because we kind of went from this to like, okay, let's try this antibody in humans and see what happens. And I think a lot of this kind of speed was because it's a rare disease. The drugs were super safe. So let's go for it. But what I had discussed with the companies is like, why don't we at least try to learn something from these studies? When I was a fellow in oncology, when you tried in rare or aggressive cancers, any kind of new drug, you always had some biopsies before and after of the tumor to see what's happening, right? And this like, is that your drug getting there? How's the biology changed? None of that happened in amyloid. I think that was a huge missed opportunity. This is an organ disease and which gave people a drug, and we have no clue why it works in some way, doesn't work in others. Do we actually see that like amyloid is being chewed up? Maybe it's not. Or if it is, why doesn't it work in all people? Right? Is it enough to remove amyloid? Are these organs kind of able to recover after you? There's so many, many like very high level questions that if you see future trials involving biopsies, still keep an open mind because that's how we will learn and advance the field. Sorry for my rant. It was my pet peeve.
No, thank you. No. It's great information. So I'd like to move into our questions, and it looks like our audience has been pretty active in supplying us with some great questions. So um, let's see. Okay, question for Dr. Tax. What do you recommend for refractory relapsed AL with T1114? Explain this, please. After treatment of 2 years Andromeda protocol, 15 months daratumumab, vacation with free light chains, only stable for 4-ish months, and now numbers are indicating treatment needs to resume. Patient is an 80-year-old, tolerated previous treatments, A-OK, and is not interested in a trial. Advice is welcome. Do you have any thoughts on that? We lost your mic, I think, Tex. Somehow you got muted.
No, I think I muted myself. Sorry. Yeah, there's two questions about kind of 11, 14, so I'll try and answer them
Yeah.
both. So at a high level, this is kind of a genetic mutation, basically, that you see in about half of patients with amyloid. And what it does, it kind of drives these cells into overproduction of light chains. Why it's important? It's not so important as what it used to be. So in the olden days, before you had daratumumab, these patients didn't respond well to Cyborg D, and we kind of shunted them towards stem cell transplant a little bit more. That doesn't seem to be the case so much. They seem to do almost as well. They are a bit more challenging. They take a little bit longer to respond sometimes, and that's a problem, right? Because you want a fast response with the light chain. So that's one potential issue. Now, the second, not issue, but like I guess opportunity is that thankfully you have what we can call a targeted treatment. These cells are relying on a specific kind of protein to survive called BCL2. And there's a drug called venetoclax now that can specifically block that. So without knowing the details and the general kind of, disclaimer here, right? You can like give advice over Zoom about somebody you've never met and you don't know. But I think if I had to kind of pick like a multiple choice question here, no doubt, I think most of us would agree that a drug like venetoclax, I know these are weird names, sorry, or Venclexta, which is a pill that you take daily, works in the majority of these patients with 11, 14. You have to be a little bit more careful with infections, but I think that's what I would recommend here.
And side effects were pretty equal to daratumumab. So for me, and I found it very effective for a couple of years. So it was, and plus being able to take it at home, not having to go to an infusion center, plus. So I was really, it was a nice segue from going from Dara, which stopped working, into venetoclax for a couple of years. So that was very nice with minimal side effects.
That's awesome. Thank you, Karen, for sharing that. So I guess maybe more and more people are being diagnosed or being correctly diagnosed with amyloidosis these days, correct? We're only getting better and better at it. Is that right, Dr. Masri?
Correct. Yes. So things are getting better. I think the primary thing is more or less, doing system change where you're finding, things early, where you're instituting treatments early, and as been discussed, that the treatments are also getting better.
And are we seeing more, what is more common, AL or TTR?
Yeah, thanks to Tax, he answered this in there, but TTR is a lot more common than AL. However, we are indirectly, as an AL community, benefiting also from that because now everybody, all the cardiologists know they should look for amyloid, and so nowadays, for every, I'm making up the number, but I think for every 10 TTR referrals we get, we're getting one AL that was thought to be either TTR or just randomly was found because someone thought of TTR. So AL is still hard to get on people's minds because of how uncommon it is, but TTR is easier to get in people's minds, and so AL is in a way being picked up a lot more, and it's not that the incidence of a disease is going up. It's just we're actually now know how to recognize it and how to find it, which is important. You need to find these diseases on the earlier side.
Yeah. Yeah, thank you. Marie is suggesting she had similar symptoms, I think, to both of our patients. She was very active, lifted weights, was a bodybuilder, and it took 15 years for her to get diagnosed. And in 2008, I believe, if I'm reading this correctly, she was diagnosed with thyroid cancer. And is there any relationship between, I guess, thyroid cancer and amyloidosis? She was seeing a cardiologist who misdiagnosed her, and she was viewed as a hypochondriac. So I guess the question is there some type of relationship between thyroid cancer? Could that have been caused by the amyloidosis?
Is this for me?
Sure.
Yeah. Well, to my knowledge, no. You have to keep an open mind, and especially, if this was AL amyloid or ATTR.
Um,
This is AL.
AL, usually, AL is a very kind of rampant disease. Within a few, it does kind of stay indolent for many, many years because I think you mentioned, more than 10 years or something between the two, but it kind of progresses very, very quickly within, a few months to like a year and a half. So less likely. Yeah. So I think probably not, probably coincidental.
Okay, thank you.
Yeah, and it's important to remember you don't need to have a unifying diagnosis for everything. If you come and hang out in our clinics, when you run a specialty clinic, you will see patients with three, four diseases in the same individual. So you don't really have to have a unifying diagnosis for every single thing that happens to patients. And common things are common. We've had patients with AL who had a heart attack. And people thought they didn't because they thought it's just AL getting worse. But no, it's not AL getting worse. It was just a new problem on top of the old problem. So you have to keep an open mind with that.
That's great advice. Lots of discussion back and forth about which type is more common. I think we've already addressed that. Okay, are there any current ongoing trials to test the new drugs and therapeutics? Pfizer used to have a drug to treat ATTR. Any insights in terms of any ongoing trials?
There are two big umbrellas there, or three actually. So for TTR, maybe it's beyond the talk of today. There are a lot of things happening. Let's just focus on AL for a second. With AL, you have essentially there are tons of trials, and Tax can expand on this as well. Tons of trials looking at hematological, approaches to address the clone itself, the plasma cells. A lot of different things happening there. Karen mentioned CAR T. There are different things, and then there is the approach of this depletion, which is you're trying to address the organ dysfunction. And on top of that, there is a new approach which will be the first to be tested, which is stabilization of the light chains. So there is a new company with likely a new trial coming, for patients diagnosed with new AL, where you take an oral pill that is meant to stabilize like the same way we use the tafamidis or acoramidis in TTR, and it stabilizes the TTR molecule. So it's still early in the process, but that's how you think about them. There are big buckets of these goals essentially, and there are many, many trials.
Thank you. Okay. Is transplantation a feasible treatment option for patients living with amyloidosis if diagnosed early? I
One
guess, Tax, you want to take that one, Dr.
one
Tax?
clarifying question. Transplantation of what?
Uh, it doesn't say. I'm
Heart. Okay, I'm going to let
heart
Ahmad
maybe. Yeah.
answer that.
Yeah, so this is really important because we shifted from 20 years ago, probably never having a discussion about this, now to every single patient who shows up to our doorstep. We think, okay, could if we can turn things around very quickly, are there candidates for heart if they need it? And so this is happening. Yes, I mean, the simple reality is if you have a lot of advanced organs involved, especially neuropathy and advanced GI and advanced other things, it might not work out. But if the primary problem is the heart and is advanced and driving the disease, yes, transplant is an option. It's sophisticated, complicated. There's a lot of things happening and that go in there, but it is an option. And that also goes to other solid organs depending on the like when I say solid organs means like heart, kidney, when it goes to there. But that's very different from what Tax was alluding to, which is bone marrow transplant. That is a different story, done for a different reason.
Thank you. Righty, let's see. Okay, could you please speak to the relationship with AL amyloidosis and multiple myeloma? My husband just got diagnosed with it after his bone marrow biopsy at Stanford. Who
I
wants? Go
I
ahead,
can
Ted.
take that. Yeah.
Great.
So we published kind of like the defining paper when I was a fellow. That was like 13 years ago. The bottom line is it's it's an academic distinction. I'll tell you. So we don't, but when you have amyloid, you have amyloid. What makes you myeloma, if you see how myeloma is defined, if you have more than average, amount of plasma cells in your bone marrow. Some papers say 10, some papers say 20, sure. That is, you can call this myeloma. You usually get the myeloma diagnosis from a pathologist who otherwise doesn't know anything about your case. If you do a scan and you see like some of the kind of moth-eaten bone lesions that you see in myeloma, you can also call it myeloma. We did this study, and basically what we found is that if you have somebody who has, cardiac amyloid and their light chains are like 100, you know, and somebody who has myeloma and amyloid and their light chains are 100, we don't care if you have myeloma. These people are going to do the exact same. What matters when you have amyloid is the amyloid and how much of that is affecting your organs, how much of it you have. So the myeloma is kind of it's there for along for the ride. Now, very frequently, you will see us kind of making a big deal and mentioning myeloma, and some of these myeloma calls can be a little bit soft. And these are tricks of the trade because you can basically get stuff approved through insurance way easier if you mention myeloma. Like for amyloid, you just have data Cyborg D approved. Everything else is a fight with insurance. But if you say myeloma, nobody bats an eyelid. So I do that all the time. It's a little bit, kind of flexible thinking. you know you have to think like a, yeah, Greek person a little bit and kind of wiggle your way around, but
Outside
like that's what you
box.
have to do with yeah, what I have to do with insurances and what's best for the patients. And then you can give off label wonderful drugs that are available for myeloma that if you didn't mention it, you'd have to fight with insurance a lot.
Wow.
Yeah.
Yeah. Okay. And then I think we have one more question just to close things out. And this is for you, Dr. Tax. And this is from Sally Cox. What do you recommend for refractory relapse? Oh, no, we already answered this one. My apologies. My apologies. Let me just make sure we are all caught up, and we are. So in closing, I guess I just want to circle back. Let's circle back to the patients first. So to Karen and Mariah, any advice, any, little nuggets or something you could give other people that are also sort of on the same journey that you're on? Just any sort of closing remarks.
My biggest advice would be get to a support group, physically or online, whatever works best for you. But get the network, because that's what keeps you centered. That's what keeps you from falling apart. It helps your caretaker to find out what needs or things that would be helpful. We've developed an offshoot group from our support group, and there's about 8 or 9 of us that go out and have lunch where we talk about other things besides amyloidosis, and we have become close friends. But it is elevated all of us to feel stronger and healthier about fighting this illness, because we're all in it together, yet we still have time to sit and share our side effects, our problems. Anybody else have it? Did you have trouble with IVIG? Did you have trouble when you were on that treatment plan? There's a wealth of advice and help out there when you get involved in support groups. So that would be my number one. And to, of course, get to a center of excellence, people who know amyloidosis and have seen amyloidosis, and not just one patient who passed away, right, Mariah? It's
Yeah.
like, push past that and get someone with, a good patient base that can give you good information.
Mariah, what about you?
I agree with Karen. The more we talk about this, the less alone we feel. And, there's a reason that scientific studies have, placebo controls. And a lot of it, I think, can be about attitude. Survival can be about attitude. And I know that in the beginning, I was extremely sad and depressed and kind of almost hoping for death at points, but I'm a lot more positive today. And so, I recommend talk to people, educate other people about what you're going through, find a support group, find other people who are going through it too, because having that community to support you is going to be your biggest tool. Don't be afraid to ask for help. Do not. If you try to do this alone, it's going to be really a lot harder.
Great advice. And how about the physicians, you all? What advice could you give to patients, similar to the ladies that have joined us this afternoon? How can a patient sort of help connect the dots in terms of all the pieces, all the physicians that need to be involved, all the hands that need to be involved? Any advice for a patient trying to coordinate all of that? Especially if they're not near one of those centers of excellence that Karen mentioned. Tax, you want to start?
Yeah, I mean, I think, I, at some point in time, I think it's a good investment to kind of establish care. You don't have to kind of get all your treatment there, but having a point of contact in an amyloid center is pretty important. Doesn't have to be done right away, but early on, and then once you're established, you can at least have access to that expertise and advice. And now we do telemedicine visits and stuff like that. So yeah, that's what I will say.
That's great advice. And Dr. Masri, any advice for patients in terms of navigating all of this?
Yeah, almost all of you being here, I think, are doing great. You already know what to do. You have the resources. You know how to manage it. I think ultimately you want to just make sure that this doesn't take over whatever else you enjoy and whatever else you want to do in life. Just keep an open mind. And also, center of excellence or not, you need to find people that will take care of you, who you trust and will bounce ideas off and things off as well. We always see this. You might see the world's best doctor, but you both might not click and things might not work out. So ultimately for a chronic condition, you just have to make sure that you're comfortable with your treatment team and whoever is taking care of you. And there is no right or wrong. Again, we're not looking at placing blame or saying one does this, one does that, but ultimately it's all about you and you being comfortable with your journey, because it's a long journey. And even after you get to remission with everything, you still get monitored, and so you just want to make sure that you're comfortable with everything that's being done.
That's great advice. And so we'll end on that point. I have a slide up just showing a couple of resources. Mended Hearts has some online resources. And then also those of you that are looking for support, check out the amyloidosis support.org organization. I know that they do an amazing job, patient-to-patient support. So thank you so much. Anybody else have anything else they want to add before we close? I really appreciate you guys. Thank you. Yeah, thank you all as well. And thank you, physicians, for your expertise, and patients. I mean, gosh, it's just really so empowering to hear what you all are doing and have done in the past to navigate. And so congratulations. And I wish everyone really good health. Thank you so much, everyone. Have a beautiful afternoon.
Thank you for moderating, Karen.
Yeah.
Bye.